You asked for automatic orders for both vaginal delivery and cesarean delivery, coming from the trauma background that you came from, treating ECMO patients, all of that. I understand totally that you saw yourself in that patient population, but like you said, okay, now everyone. Like you started with everyone.
C-section felt obvious, right? We want to see the surgical patients. I was worried that if we only limited it to C-section patients, that I wouldn't be able to see enough patients in a day to keep the program alive. And once I started doing, getting involved in this, doing more pelvic floor education, I realized that there's a benefit to seeing vaginal delivery patients as well. Even if you didn't tear, even if you didn't have any complications, there's still, I find it very rare that even the most uncomplicated vaginal delivery patient doesn't have something going on. They have a little bit of back pain from their epidural. They are not feeling as emotionally attached to their baby as they thought they would. Even if they don't have anything physical going on, we go in and we talk about the mental health aspect of it too, right? And even if it's just 8 minutes of education to tell them what to expect in the next couple of weeks. I give them education of signs and symptoms of pelvic floor dysfunctions. Some people are like, I'm ready to get back on my Peloton like tomorrow. Can I do that? And, we talk about like safe ways to start exercise and like get back to activity. So even if it has nothing to do with like physically being in the hospital, there's always something that we can educate them on. So I just wanted to make sure that we were trying to at least get in touch with everybody, or at least have the order available, so that way we have the ability to do that and to get in the room. And even if they're like, nope, I'm good, I got nothing for you, and I have a packet of information I give everyone, so that way they at least have a packet of papers that has my education on it that they can go home with, even if I don't actually see them.
This is such a great reunion because I think the last time, Dr. Sisler, that we've actually been on together, was it 2022 or 2023 or something like that?
Yeah, it's been a while.
Yeah, I mean, you can even go back. So a lot of what we'll be talking about, it actually has a start, and it was one of the first videos I put like this on YouTube. Marley, I feel like you should tell that story because you reached out to me and I said, yeah, that sounds like a good idea. Like, let's do a panel and let's interview moms about their experience and let's do this. And I don't know that I really put it together that this was really part of a bigger project, capstone experience and things like that. So I have so many like memory lane questions to go down. But a large reason for this was that we have been getting quite a few OTD students who are completing their capstone projects. And really, I just, at this point, I'm always constantly looking for like, where are people now who did an OTD capstone like you did? And it turned into a program like yours did, and it affected so many people. And so I would love to just like revisit that conversation so long ago, how that got started, because a lot of it is actually the foundation for um, program development in general from a student standpoint. And so, can you take me back there? Like, how did you reach out to me, and how did this all come to be?
Yeah, absolutely. Well, first of all, just thank you for having me back. It's always a pleasure to talk to you, and just seeing like how we both have like grown programs and your company and stuff since we started this conversation in 2023. It's just really cool to see. So, yeah, so going back to the very beginning, I am coming up on working in the acute care setting. It'll be 5 years, I think next week actually. It was my very first job out of school. It was a fieldwork rotation that I did. So I just fell in love with the setting, and wanted to work there. And that just worked out in my favor right after school. So it was this whole thing actually started on that job orientation. So I work at a level 1 trauma center. I work for West Virginia University Medicine at our flagship hospital in Morgantown, West Virginia. So like I said, we're a level 1 trauma center. So we see a bunch of different people. We have, I think, probably 40 to 50 OTs that we match with PTs as well at this point. So we're a pretty big department. We see trauma, ortho, neuro, cardiac, med surg, oncology, um, observation, long-term infusion, like you name it, we see it. We have a pediatric team as well. But what wasn't in that at the start was obstetrics. So on my orientation, we do a week-long orientation with every team, week of ortho, week of neuro, etc. And I was on our cardiac orientation, and this was in August, around August, September of 2021. So the Delta variant of COVID was going around. And the only reason I remember that so clearly is because I was getting married that September as well. So I was like super panicked about what COVID was going to do to my wedding. So COVID was still pretty bad, 2021 bad, but not like 2020 bad. Um, and so we were seeing a lot of moms in our cardiac ICU that were pregnant, got COVID, and then their lungs just could not keep up with the pregnancy or their body anymore. So they were coming into the hospital and having these really preterm deliveries, needing emergency C-sections and then being placed on ECMO, which is a machine that pulls the blood out of the body, oxygenates it, and then puts it back into the body. And even being able to see patients from a rehab perspective on that life support device is a whole other program that one of my friends has started, and she's done a lot of research on that too. So it's super cool to even be doing that and then to be seeing an obstetric patient, which wasn't really a thing in OT at the time anyway. So just two very unique situations in one patient. So my mind was just blown from that. So I was seeing these patients, we're doing the ADLs, we're doing the bed mobility, just the very simple things like really starting to get them moving. And it just got my mind thinking, these moms, once they're out of here and doing well, they're going to have to do a lot more than just their own ADLs. They're going to have to be able to take care of a newborn and a premature newborn for the most part. So it just got my brain thinking, like, what more could we be doing that isn't in just our normal scope of practice and what we're just doing in normal acute care things. So my capstone project idea, I was starting my capstone. That was in fall of 2021. I was starting my doctorate program in 2022. So I thought, well, my capstone will just be what's the role of OT with ECMO moms in the ICU? And then as I got through my program, luckily, COVID got better and we weren't seeing as many moms in the ICU, which was a good thing. So then I just started thinking, well, what is the role of OT in just general obstetrics? How are people even doing this? Like, how can I get into this? I've always had an interest in obstetrics and, pediatrics kind of. I would never consider myself a pediatric therapist, but just something with like newborns. Like I just love babies. We did a research project on it in school and thought that was fun. So I got on Facebook and just searched up like OTs in pelvic health, OTs in obstetrics. And that led me to Lindsay Vestal's Facebook group, OTs in pelvic health. And I just asked a question in there. Does anyone work in obstetrics? If so, how, like, what are some continuing ed classes that I can do to, kind of get into this and just see what this is all about, if we even can. And that's when your program, Enhanced Recovery After Delivery, was introduced to me. So a bunch of people said, yep, if you want to work in obstetrics, this is the program you have to do. So that's what I did. I enrolled in ERAD, got started there. I think that was in 2022 as well. 2022, 2023. The timeline kind of runs together. So did the ERAD program and started the capstone portion of my doctorate, which my capstone advisor, Dr. Kendra He-Walshank, was super supportive of. She was really interested in the topic as well, which became how to start an OT program on a birthing center in a hospital setting. How do you do this? And what do you do? So it was, and at this point, there was very little research of like OTs working with moms, working in the hospital with, obstetrics. There was a good bit of research in other countries that were doing it, but very limited in the US. So that is kind of how I got started. And then I can talk more about kind of the steps I went through if you want, or you just tell me whatever.
Your path to this obviously is so unique coming from the trauma world, but then also going back to complete your doctorate. Is that right?
Yeah,
Right. And so your capstone happened when you were already a practicing clinician,
correct.
already, obviously, you've been doing this for 5 years. And so I get really excited when I see, other people in the room who have their own journeys into this. And one thing that stood out, I think a little bit later when we met was like you were not a mom, at this time, right? You had an interest with
Hmm.
this population, obviously, had some touch points in OT school, but you were really paving something without a roadmap. Yes, there was a course out there, but there were other programs and touch points, not a lot of research. And so I really just want to just set the stage and just welcome the people in the room who are also doing this in various settings as well, not just acute care, because there's a lot of just nuances that I think that you're about to share in terms of the communication it took, in terms of the relationship building, which was a big part of it. And then
Hmm.
just also just in terms of like the data gathering and how we came to know each other. So if you are joining us, you've been part of program development. I know that some of you have, or your students, and you're like, hey, I have an opportunity to do a capstone somewhere. There's this directory that I heard of where there are hospitals that are offering OT and PT on the maternity unit. You have someone here who developed and designed her capstone around this patient population. If you can actually start putting your questions in now, this is a live conversation. This is for your benefit. This is providing me with such deeper insight into the backstory behind when Dr. Sisler reached out to me that it just gives me goosebumps. I'm so happy that she's speaking. And so please pick up from where you left off. But I wanted to just like set the stage and just welcome the people that are in the room and definitely you pioneers that are in the audience that are live with us tonight. Thank you so much for being here. But yeah, Dr. Sisler, if you'll just continue with your story.
Yeah, absolutely. So program development was a big part of it. So we take that course in, OT school when you're getting your master's, and then you take it again when you're getting your doctorate. So, and I wish I could remember what it's called, but if you've taken program development, you know that like flow chart thing that goes like across the paper and it has like the inputs and the outputs and the pros and the cons and whatever that thing is called. So they made me make that with all the fun arrows and boxes of like why this is a good idea. Strategic planning, I think, is what it's called. So I made my strategic plan, and then my capstone advisor and I kind of worked together of like, well, how do we figure out what OT interventions we even do? So I started with ERAD, which gave me the great foundation of just like learning what even are OB diagnoses, because we don't learn these things in OT school. What are OB diagnoses, and then how do we use our rehab skills to treat these diagnoses in various settings as well? So that gave me a really good foundation of being confident and being able to say, okay, I'm an OT and I have this toolbox of interventions that I can use, and I feel confident in treating these diagnoses as well. But before even doing that, started with research of like what countries and health systems even have this kind of work in place. What other countries are doing this? I think it's in the UK. I thought it was really interesting that every mom who delivers automatically gets home health nursing and rehab, regardless of like what delivery that you had, which I thought was really cool. So just gathering data of like what other countries are doing this. They have really good birth outcomes. They have really good, maternal health rates. This is great. And here in the US, our maternal morbidity is really high and we have a lot of really bad health outcomes, and OT is only going to make this better, right? So started with a lot of research of what other places are doing this. The next thing that I did was I wanted to know what moms wished they would have known before leaving the hospital. So the best way that I could think to do that was just to interview a bunch of moms. So I interviewed moms that I work with, so PTs, OTs, speech therapists who have that rehab setting that could say, these are the skills that I know my patients benefit from that I wish moms who don't have a rehab background would know, which a lot of things were like abdominal protection, diaphragmatic breathing, edema management, things like that that we know that are second nature to us, but the general population does not know. So that was really good insight as well. And then I interviewed moms that aren't rehab therapists and just said, what do you wish you would have known before getting out of the hospital? I interviewed them via Zoom, in person, messaged me on Facebook, like whatever people were willing to tell me, I was willing to listen to, and took those physical issues, psychosocial issues, and a lot of it were things that rehab could address. It was really hard getting in and out of bed. It was really hard putting my underwear on. It was really hard taking a shower after a C-section. I wish someone would have told me how to do these things, and maybe they figured them out for themselves, or maybe they didn't and they still didn't have the answer to how to make that better. So took all of that information and categorized it into physical difficulties and psychosocial difficulties. And then came the portion of talking with you. So at that point in ERAD, when you finished the course, we had to do a presentation of some sort, about like what we'd learned and how we can incorporate this. And that's when I had reached out to you and said, hey, can I do my portion of it on an interview with maybe some other rehab professionals that are doing these programs and moms that like what they wish they would have known, kind of still doing that like qualitative research. And that led to, I think, a 2-hour interview with you and I and a bunch of moms, just talking about birth stories, good and bad, the role of PT and OT in the hospital setting and other settings, and how we are going to be able to help moms all over the world. And it was just this really great conversation of why these programs are needed. And that was such a really good interview that really helped with my capstone as well. So that was our introduction, and then kind of went from there with our relationship. So at this point, I've gathered information on other countries' health systems that, routinely use rehab and obstetric care. I've talked with moms, I've talked with professionals of how we can help this population and why it's needed. So then I put all of that information into a really big PowerPoint, wrote a really big paper about it. And then I talked with the actual OB staff at my hospital and said, hey, I have this project idea. I'd really like to introduce it to you guys, and talked with my management as well. I did talk to my management first, so I had to make sure they'd even let me do it, right? So talked with my management, and they actually said, well, funny you say that. Someone wants to start an outpatient program. We're building this outpatient clinic, and they want outpatient pelvic floor PT and OT. Would you be interested? And I said, not really. Outpatient isn't really my thing, but I would be glad to start an inpatient program to then bridge them to that outpatient program. And they were like, well, okay, we'll see. Give us your presentation or whatever, and we'll see what we can work with. So got their, blessing to continue on. Got in touch with I just Googled the chair of our OB department at that time, got her email, sent her an email and said, hey, I have this project idea. I'd really like to speak with you. And she was open to it. So we set up a meeting, and I gave her, my spiel. I'm an OT. I work at the hospital. I've been doing a lot of research on the benefit of OT with obstetrics. I really think that I would like to work with your patients and really see what we can build from this. And that was a really cool conversation. She was really open to it. And she said, I will never forget, she said, I'm really embarrassed to admit this, but we used to have a PT that would do that did this. They did this in the hospital setting for us. And then they moved, and, it just kind of fell through the cracks. And she said, I never thought to ask an OT to do this. And I was like, it's okay. Like a lot of people doctors aren't always trained in what OTs are. Sometimes OTs don't even know what we do. Like, we are such a broad scope of what we can do. Like, I think sometimes we're even hard to define ourselves. So I said, it's okay. I'm not trained on what you do as an OB. Like, it's okay. But I'd love to build that relationship now. And so she said, my suggestion would be to take your presentation and present it to our whole staff at our grand rounds, whenever you're ready. So I said, okay, we'll do that. So that was in the fall of 2023, was wrapping up my capstone, wrapping up my dissertation, presented it to my school. that went well. And then grand rounds came. I did it on my birthday. I don't know why I thought that was a good idea because I was like, if this falls through, this is going to be a terrible birthday. But I presented it to the whole OB staff, nurses, doctors, midwives, PAs, NPs, all of them, and took all of this data that I've just talked about and gave it to them and gave it my best shot, and they loved it. Immediately got off the Zoom and were like, "Okay, let's put they put orders in that day." And I was like, "Oh wait, we're not quite there yet. That is a lot." Wasn't quite ready for that. And turns out I did see my very first patient that day. Like they had someone that like really actually needed therapy in a bad way. And so I saw my very first patient that day. So that is the long story of how we got there. So that was in November of 2023. Talked to my bosses and said, "Hey, the OB department is like really down for this. They want me to start seeing patients like now." And they were like, "Oh, okay, I guess go for it." That I have a really great job that I work for. I have really supportive bosses that have supported this program from the beginning. So, I will be honest with you, I don't think this is the normal course for a lot of people. I think there is a lot more pushback normally to do this than I got. I don't know how I got so lucky, but I do think I was lucky in that I have a really good boss and I have a really great OB staff that we work with and have built a really good relationship with. Um, so then, and I think this part is important too. Once we got that rolling, I did a meeting with the nurses on our birthing center and just wanted to introduce myself. And because nurses on labor and delivery are really protective of their patients, rightfully so. But like a new face comes in and they're immediately like, "Who are you? What are you doing? And why are you in this room?" Rightfully so, right? They've got two very vulnerable people to take care of. Um, so I wanted to introduce myself and just say, I'm not coming to step on toes. I'm not coming because I don't think you guys are doing a good job of like mobilizing your patients or getting them discharge ready. I am here to help you and to offer my services and so that we can work together. So I think that part is really important too, because I've been able to build really good relationships with the nurses that we work with. So all of that happened at the end of 2023. I told them we would be ready for, I asked for automatic OT orders for C-section and vaginal delivery patients because I wanted to be able to make this my full-time caseload. If I only asked for C-sections, I was scared that I wouldn't have enough patients for it to be a full caseload and that it wouldn't be as successful a program. So I just went for it and said, I want orders for everybody. And they said, okay. And so in 2024, we fully launched. It took a couple of months for it to be, fully automatic. One of our residents actually was like, why don't we just make this part of their postpartum order set? Because the physicians were and the midwives are still having to manually put in the order, but making it part of the order set once, because everybody gets postpartum orders once you deliver. Once it got put in that order set, they didn't have to manually put it in anymore. So now once postpartum orders go in, OT orders automatically go in for all vaginal and C-section patients at our hospital, regardless if you had an uncomplicated vaginal delivery or you had the most complicated vaginal delivery. We're coming in to see you and see how you're doing.
One question I wanted to just back up and ask. When you did that grand rounds, you invited me to that. That was like the first time I've ever like that's the first time I ever obviously seen you speak. But I was there. I remember that.
Yeah, actually, I forgot about that. I think you were at that, and I think you were at, I did a meeting with my department as well.
Okay.
I forgot about that. Yeah, so before I did the grand rounds, I wanted to make sure that my coworkers were on board with
That
this
is,
as
I
well.
think I was there. I think I was
That's what you were
there.
at.
Okay,
Yeah,
so all right.
that's what you were
So
at.
back up because the whole automatic order thing, I think that's where I might be it's hard to like explain, and which is why I'm like so grateful for you to say yes to speaking with, students who email us and say, I want to do this thing, but I don't know where to start. And you give your time, to each and every student who just wants to meet with you and ask questions. So this is actually really good because I have a big question about this is that before you even did automatic orders, did you ever think, well, I actually have just completed my capstone. Like, what made you want to keep going beyond the capstone? Like, you had already completed all the criteria that you wanted. What made you say, I want to do this as a full-time job when, I mean, you were all over the hospital. Like, what made you want to say, this is going to be my home for a while. I want to stay here.
That's a great question that I don't really know if I've ever really thought about that deeply, to be honest with you. I think looking back, I've always had an interest in like obstetrics and something along the lines of like newborn care and something with moms and just like overall well-being of women. Like I think in my next life, I want to be a midwife. I love being an OT, but like I just love women's healthcare and I love babies and I just want to be around them like all the time. But you're right. Like I could have just done that and then just been like, okay, like I'm done my capstone requirements, like whatever. But it was just, and I think it's just because we had never done it before, and I just wanted to try it and see, if it would work. And I'm seeing patients that are similar to me and like close to my age, and like I could see myself. I think that's what it was. I could see myself being in their shoes one day, and I wanted to be the person that they needed in that moment that like I could maybe need one day, if that makes sense. Like I wanted to be the one to help them and be there for them and listen to them. And because as OTs, we have the time and the resources to do that. Doctors and nurses, they're so busy, they're in and out of their room really fast and they have a bunch of things going on. But that's why I love our profession and why I went into OT, because we have the time to sit down with people and really get to know them on a deeper level and really ask those like deep, complicated questions, like really, how are you doing? And like, what are you actually struggling with? And we have the time to allow them with that. So I would just wanted to try that opportunity and see if that's something that, we could create something out of in our at our hospital.
But what made you, with your background, I'm glad you said that you love babies because I might be having my son join us. He's been,
I would love it.
I would love it too, because he would love it too. He's just been staring at me while he's been trying to get over to all the cords that I have. But one big question I have before we go to the audience questions, because they have some really, really great, you know, scenarios that they've also been through, which I think that you're probably the best person to shed light on other experiences. But what made you want to jump full, like head on in? You asked for automatic orders for both vaginal delivery and cesarean delivery, coming from the trauma background that you came from, treating ECMO patients, all of that. I understand totally that you saw yourself in that patient population, but like you said, okay, now everyone. Like you started with everyone.
Yeah, I just didn't want to be completely honest, it was more of a worry about keeping the program alive in my own productivity. Because we have a productivity, standard that we have to see a certain amount of patients every day. And I was worried that if I only, C-section felt obvious, right? We want to see the surgical patients. I was worried that if we only limited it to C-section patients, that I wouldn't be able to see enough patients in a day to keep the program alive. And once I started doing, getting involved in this, doing more pelvic floor education, I realized that there's a benefit to seeing vaginal delivery patients as well. Even if you didn't tear, even if you didn't have any complications, there's still, I find it very rare that even the most uncomplicated vaginal delivery patient doesn't have something going on. They have a little bit of back pain from their epidural. They are not feeling as emotionally attached to their baby as they thought they would. Even if they don't have anything physical going on, we go in and we talk about the mental health aspect of it too, right? And even if it's just 8 minutes of education to, tell them what to expect in the next couple of weeks, I give them education of signs and symptoms of pelvic floor dysfunctions. Some people are like, I'm ready to get back on my Peloton like tomorrow. Can I do that? And, we talk about like safe ways to start exercise and like get back to activity. So even if it has nothing to do with like physically being in the hospital, there's always something that we can educate them on. So I just wanted to make sure that we were trying to at least get in touch with everybody, or at least have the order available so that way we have the ability to do that and to get in the room. And even just, even if they're like, nope, I'm good, I got nothing for you, and I have a packet of information I give everyone, so that way they at least have a packet of papers that has my education on it that they can go home with, even if I don't actually see them.
Awesome. The last 30 minutes of this, I want to open it up to everyone. My last question for you, and this is a little bit sensitive, and a few people have reached out, if we're rightly so. This was mentioned, I think, on one of my calls several years ago. And then Dr. Sisler, you emailed me about, a particular patient, which feel free to delete any details that you don't feel is appropriate. But it was all around the topic of maternal mental health. And that email from you spurred the one of the biggest like conversations and decisions that we made to partner with Lindsay Vestal and create the Trauma Informed Maternal Health Scholarship, because we not only wanted to just acknowledge how early these rehab services were actually catching and picking up on some maternal health concerns postpartum, but they were also identifying the therapists that were taking a lot on, like this was really heavy. And I wanted to just kind of just highlight that moment that I had with you, because obviously like our relationship has continued, since all these years. But I just want to like at least say it, if I haven't said it to you publicly before, that I think you are the single like reason as to why we started to really expand a lot of the work we were doing for mental health postpartum. And I want to just thank you for that. But would you mind sharing any details you feel comfortable? And then I'll call the first person up to ask their question live if they feel comfortable. But will you share anything about that, like things that you might have noticed on the maternity unit that just made you realize this is way bigger than vaginal delivery versus C-section. We need to see every mom.
Yeah, absolutely. And thank you for saying that. I will just say, since, hi, cutie boy, since becoming a mom myself, I have dug so much deeper into the mental health aspect, because my own mental health journey since becoming a mom has been a lot different than I thought it was going to be, as someone who never really struggled with mental health before and did in postpartum. So that I take it a lot more seriously now. But two patients come to mind. The first one was a patient who had known psychiatric mental health history, and she had a baby. I genuinely don't remember if it was her first or if she had multiple, but I just remember walking into the room and her demeanor was kind of off. She was a little bit standoffish towards the baby, had made a couple comments about the baby, just being like really fussy and really kind of like annoying. And then she called the baby a name. I genuinely don't remember what it was, but she called it a name that didn't sit right with me. And then I will tell anybody that I work with, if you have a gut feeling that something is wrong, just tell someone, tell the nurse, tell the doctor, because you don't want to keep that on yourself if something does happen. And I would rather tell someone something and it be absolutely nothing than find out later that something went wrong, So I told the nurse, like, hey, just what I had seen. She made some comments about the baby. I think we should maybe get psych in there and just, she has this history anyway. It probably wouldn't be a bad idea for them to work with her while she's here. I think psych should be working with people on the maternity unit a lot closer than we are. Just the chemical change that happens to you after you have a baby is so significant that we need a lot more psych care, but that's a whole other podcast. So anyway, and long story short, she ended up talking with psych, and she admitted to them that she felt like she was on the verge of like a bipolar crisis, like a manic crisis, that I believe that I had caught. So I was really, happy about that we were able to catch that, and we were able to adjust her meds and get her, outpatient follow-up scheduled before she was discharged from the hospital. So that was more of the patient side. Personally, working on this unit, when I had reached out to you, I was struggling with my own infertility journey at that time. Um, was working with moms all day long. My husband and I, we basically started trying to get pregnant right when I started this program, and had done it for a couple months at this point and still wasn't pregnant. You know, every day I'm walking onto the unit, like trying to imagine myself in this situation, right? So it got, I'll be honest, it got kind of dark. Like it became my favorite, it was my favorite population to work with. And it very quickly became something that I really wasn't excited about because I was just so deep in my own grief that I just wasn't excited to go to work anymore. And then I had a patient who, had a seizure on me in the hallway and she was getting ready to be discharged. She was like getting ready to walk out the door. Um, and she had a seizure on me in the hallway. And she had a diagnosis of pseudo seizures that was not that wasn't listed in her chart. So that's something that I take a lot more seriously now too when I see that, because there's a lot of controversy about, you know, the diagnosis of pseudo seizures anyway. But whenever you have someone that's gone through such a physical and emotional change, that's something I take really seriously now. So on top of dealing with my own grief, plus literally catching her in the hallway from hitting the ground and just thinking like she was literally about to walk out the door. That could have happened when she was holding her baby. That's when I reached out to you and was like, I think we need to start. We're doing all this work to take care of the patients. This can be a really heavy population to work with mentally as providers. So I think we need to do something to make sure we're taking care of our providers as well, because it can get really heavy on you. And I would love to actually talk with more like OB providers about that too, and just like what they, you know, experience, especially with deliveries and stuff, because I know it got kind of dark for me a little bit. And then once I was able to talk to you and you were kind of able to help me like talk off a ledge and like get grounded back into like why I do what I do. And like, I know you and Lindsay have done great work in like the trauma informed care, for patients and providers too. So I think that's really needed and really great work that you guys have done.
Thank you so much. I remember all of those scenarios. Thank you so much for bringing me back there because, yeah, I agree. I mean, just more can be done. And obviously, just in the light of just nationally what we're focused on right now, our postpartum mental health disorders.
Yeah. Yep.
Um, Natalia, you're the first person who asked a question here, and I would just love to go down the list. A lot of these questions, they they're quite full, and I want to give anyone else the floor who just wants the opportunity to engage with this amazing person. So please, I'll bring you up, and then I'll I'll get rid of myself because I have a little one I need to rally. But yes, Natalia, please go for it.
Hi, Dr. Sisler. I'm so happy you are here. I actually messaged you and you're like, I have a talk coming up, and I'm like, I'm coming. Um, so thank you for being here. Thank you for sharing all that you shared so far. I'm sorry I look like this. I just dealt with a tantrum. So full
Get it, girl.
mom
You're
life
good. I
going
get
on.
it. You're good.
So my message is about my own program. I am I feel like I'm in a women's health war with my OTD program. There is just like wall after wall that I am just hitting, whether they're telling me that I need an expert in order to complete a program, or that I need to add additional things in order for my program to be complete, or saying that I need to go outside of acute care because as an OT, that'll benefit me if I focus on things outside of acute care when I really want to focus within acute care. So no matter what it is that I'm trying to complete, there's always like some sort of blockade that I feel that I'm like fighting. So I just didn't know like what the conversation was with your school, who your committee was, just anything that you, I don't know, just said to kind of get that through, or maybe they already had some acute care experience. I'm not sure. I just know that I'm like literally on the verge of quitting. And I am like at the very end, like I paid for it all. This is the very last step. And I'm about to just move everything somewhere else because I just don't want to complete a project that I don't know anything about. For example, they want me to complete a pelvic health project, like very centered pelvic health. And I'm not a pelvic floor OT. So I'm like, I cannot complete a project on pelvic health. So just anything that you want to say to me might just kind of spark some ideas that I can kind of go off of.
Yeah, yeah, absolutely. And I'm really sorry to hear that you're like struggling so much with that. I know like just like the whole OTD thing is like so stressful in itself. And then when you have like fieldwork issues, it's like literally it's so stressful and so annoying. Um, so I will say I feel like my experience was different because I was already a therapist working in the hospital
I
versus a student. So I think
it's a
that's where my
it's a
experience is different.
sorry. I'm a post-professional student, so I'm 3 years working at a hospital here in Illinois.
Oh, okay. So you are working in the hospital. Okay, great.
Yes.
Because I was like, I know. I'm like, I get these students and I'm like, I don't know how to do it, like not as a working therapist.
Yeah.
Um, if you want, I will send you. So I have some data. I did some data before we got started, just of like how many patients we've seen and stuff. So the way that I kind of framed it to my management too, and maybe you can even do it with your OTD was like we're going to make the hospital more money, right? Because we're going to be seeing more patients. We're seeing a whole other floor of patients that we've never seen before. So we're only going to be making more money. We're going to be seeing more patients. In the last 3 years, we've seen over 6,000 OB patients. So the 6,000 more patients that we didn't see before. So that might be something that you can take to your capstone. I was, like I said, they wanted me to do outpatient pelvic floor as well. And I just kind of stood my ground and said, no, I'm not an outpatient therapist. Why would I do that? I don't want to. Um, so yeah. And I kind of just took my whole plan to my management, and my OTD capstone was really, excited about they were, as long as my management was okay with it, they were fine with me kind of doing it. So maybe if you could talk to, if you've reached out to anybody on the OB service and just see if you can get their input, if they would be agreeable to having you working on their floor and just, getting
So
input from them from a physician standpoint.
yeah, so I'm actually working the other direction. So my hospital system has already started an OB program. I'm the OT that started the OB program. What I'm trying to do
Okay.
is actually build a protocol for OTs of like, this is what we go over, this is what we teach for other clinicians. And it's the schooling, like the university, that I'm having the pushback from. But the actual program with like my hospital setting, I'm doing the thing. So I just don't know how to talk to the university side of things and why there's so much like, oh, you need an expert to be able to complete a program type of conversations that's going on the university academic level.
So I have a friend that's one here right now.
Okay.
If she's willing to come on, Kaylee, you don't have to show your face if you don't want to, but I feel like you are more equipped to answer this if you don't mind. So my friend Dr. Kaylee Nolan is an OT and works at West Virginia University as faculty and helps with fieldwork placement and all of this. So Kaylee, I'm going to phone a friend because I feel like you might be more helpful in this if you don't mind.
Oh my goodness, I'm causing chaos,
Yes.
Rebecca. I'm sorry.
Hey, we
No,
love
no.
chaos. Thanks, Marley, for asking me to come on. Hi, Natalia. It's nice to meet you. Like Marley said, I do our outpatient maternal health clinic, but I'm also our capstone coordinator at West Virginia. So I do understand the school side. So does it sound like, just so I'm clear, is it more pushback on like the project part of the capstone? Because it seems like your experience will be very well put together since you're already in the hospital, but the pushback is from meeting project requirements.
Yes, so they are every time I present a project on that project proposal is where I'm getting really stuck because I will submit like an acute care obstetrics OT what we're doing, and they'll be like, no, add 30 minutes of sexuality education at this. And I'm like, we don't have 30 minutes to talk about sexuality. And then there's like it's like meeting after meeting for these like conversations because it's acute care. I feel like my program doesn't have that acute care conversation no matter how much education I've kind of provided. So any type of like project proposal that I have submitted thus far, it's taken like 6 months and it still has not been approved. So yeah, I'm really stuck on that proposal.
Well, I don't want to take up too much of Marley's time, but I would be happy to send you my email and we can continue this like after the call of like if you want me to look over and provide any feedback. But it sounds like you have like they want a well-rounded program and you're able to do that, but we have to do it obviously within the bounds of acute care and how practice is done. So I would be happy to support you and kind of like continue this after. Again, just don't want to take up too much of Marley's time.
Yes, me too. I would love your email and kind of chat outside as kind of there's other people with other wonderful questions that I wrote in the little chat. So yes, thank you so much.
Yeah, and I will. Kaylee's the best. Kaylee was my fieldwork coordinator. She's whose job I took when she went to faculty. She's does our outpatient. I do the inpatient. She does the outpatient. She's the mental health certified. She's the best. She does it all. I love her. So yeah, and Natalia, I'll send you my capstone PowerPoint that I presented for my dissertation as well. So hopefully that can give you any little tidbits that can help with your proposal too. I'll send that to you after this, but I'm sorry I couldn't help you more.
No, that was very helpful. Thank you so much for all your input and for phoning a friend. Sorry for all the chaos.
Yeah. No, you're great. You're great.
You're fine. Thank
Hannah
you, Kaylee.
Richards is the next question, if Hannah's around.
Hi, can you hear me?
Hi, Hannah. Yes,
Okay,
perfectly.
Yes. So thank you so much. My question is, can you share a little bit more about what statistics hospitals find convincing when you're trying to introduce an acute care pelvic health to a new location? Where I just started my residency, we have really robust outpatient women's health, and we're hoping to do more and more introducing it to acute care, but we have to get not just our PTs on board, but also some more leadership administrative aspects. And so I was wondering if you could talk a little bit more about what are some of the statistics that you provided to your hospital that had them really enthused for your program?
Yeah, absolutely. So I went really deep into hospital like metric data. So readmission rates, length of stay, cost of admission, patient satisfaction outcomes, things like that. So I basically just found those like standards of care along with like just maternal morbidity standards, maternal health standards, any diagnoses that I felt like OT could have an impact with as well. Took that like general and then maternal health and then how OT can help all of those things. So my whole capstone paper was basically like, here is pelvic health dysfunctions and here's what they are and here's how OT can fix this in the hospital setting. So it was like, I don't know, like 56%, don't quote me on this. This is just like random, but 56% of postpartum women experience at least one pelvic health or pelvic floor dysfunction. How in the hospital setting can we say, if you are peeing your pants for the rest of your life after you have a baby, that is not normal, despite what your mom or grandma may tell you. Those things and saying like, this is how in the hospital setting we can reduce these statistics, if that makes sense. Length of stay rate is however many days for OB patients. If we do OT in the hospital, we can maybe reduce that by a day or half a day or something. Readmission rates are caused by half our readmission rates are caused by preeclampsia. Again, that's just made up. I don't know. If we do OT here in the hospital and checking their blood pressure more often and educating on like getting a blood pressure cuff at home and talking about blood pressure at rest versus activity, can we reduce their readmission rates or can we bring them to the hospital sooner before they're having really bad outcomes from postpartum preeclampsia? I hope that kind of answers your question there. But what I've learned in the hospital setting is anything you can talk about money, data, and numbers is the really big buying in points for you. And Rebecca actually has a paper on this, right?
Yes.
Because I used that paper.
Yes.
Phoning another friend.
I will. I think I'll link any of the articles. Not all of them, unfortunately, are open access, but the first one was. that really addressed a lot of more like how do you approach the buy-in, how do you initiate this in the hospital. So I'll link that to this. This um, will be made available to everyone who might benefit.
Thank you so
Was that
much.
helpful?
Yeah,
Awesome.
that's really helpful. Thank you. And then, sorry, I had a part two. How was managing the ERAD education while also finishing your degree while also still working? Like, how did you manage all that from a work-life balance perspective?
I'll be completely honest with you. I worked a little bit less. So when I started working, I was working 40 hours a week, and I reduced my hours to 36 hours a week so I could have one day off during the week just to dedicate to school, which was just school at first. And then once I started the ERAD program, I dedicated time to that as well. So I had one day off during the week that I dedicated just to school and continuing education. And I felt like that gave me a really good work-life balance because I just knew that if I was going to be working all day and then have to come home and do schoolwork or just do it on the weekends, that I probably wasn't going to finish the program successfully or in a very timely manner. So I talked with my bosses and they allowed me to change my schedule and decrease my FTE to working 4 days a week instead of 5.
Thank you so much. I really appreciate it.
Mm-hmm.
So helpful to
Yeah, of
know
course.
that you did all that. Okay,
I'll never work
Lauren,
5 days a week again if I don't have to.
I, uh, Lauren, uh, yes, go for it.
Hi. Yep. Thank you. I'm really excited to be here. So a couple years ago, I tried to start a program at my hospital system, but the director of women's health at that time kind of shut it down. So I'm coming back guns a-blazing this time. So I'm really excited to be here and listen to all the wonderful things that are going on. I think I do have the support of my own director behind us now. I'm in management. And so we're looking at things from a system perspective. I work in a large hospital system with 5 different locations that offer OB services and labor and delivery. So I think from a volume perspective, we're really concerned about being able to staff all of that. In 2025, we saw 7,500 deliveries across those 5 hospitals. So I think, do you have any experience, or can you speak to kind of the staffing challenges that might have occurred, or what staffing looks like now with your volume?
Yeah. Okay, so I just want to make sure I'm like getting this right. So you would be trying to staff 5 different hospitals, right?
Yes.
Okay. So we only are in charge of like my hospital, which has like an average of like 20, I think, what was it? In 2024, we had just under 2,700 deliveries per year. So quite a smaller number compared to year 5. But for staffing for our hospital, so that was part that I should have talked about more in the beginning. So during the capstone process, I had a department staff meeting, showed them my capstone presentation, and I said, I just want to make sure the rest of you are on board with this as well, because, if I'm ever out or like I decide that I need a change and we start this program, I don't want it to just fall to the ground. Like we're going to need a couple other people to be on board with this. And luckily, a good bit of people were interested in helping out. So we did training for everybody. So anytime, we get a call on the weekend that an OB patient needs seen, all of my coworkers are qualified to go over there and see that patient. So as far as training goes, I did just a bunch of in-services and presentations and case studies on working with the OB population, took info from ERAD that I had learned. These are the diagnoses we need to know. This is how we treat them from a rehab perspective. And here's a couple case studies of like real life situations. And then for staffing, so for our population, we really only have enough patients to need one full-time OT to see everybody. So that's like 40 hours of FTE a week for us. we have a couple other people that are trained to work this team full time. So when I was out on maternity leave, one of my friends took that over. She did it full time. Now I'm part-time now, actually, and one of my other friends is part-time. So her and I split the team together. Um, so as far as staffing 5 different hospitals, I guess you would just need to see my best, and that's how we determined for us what we would need staffing wise. Our unit is 30, 30 beds and then 4 triage beds, which we typically don't see anybody in triage. But having 30 beds, half of those are labor beds. We maybe, and just talking about with the OB staff of how many postpartum patients do you even have in a day? So we were able to get their numbers and say, okay, there's probably going to be about anywhere from 5 to 15 OT orders per day for our birthing center. How many OTs do you need to service that? And we tried it out with just one, and that's been working for us thus far. So that would be my best advice, is just talking with those 5 hospitals and seeing how many postpartum women you would have getting orders per day, and then going from there to see how many PTs and OTs that you need to staff it. But it's a great problem to have if you're having 5 hospitals to staff. It sounds
Yes.
really overwhelming, but that's a great problem to have. That's something that we're trying to do in because we're a big hospital system as well. And we have a couple other hospitals that are starting this program, but that would be like my dream to have, this program across a bunch of our different hospitals. But I hope that was helpful. That
Definitely.
answered
Thank
your
you so
question.
much. Yeah, I really appreciate
Mhm.
that. I think that gives me something to go off of, and I'll take that back to my director. So thank you so much.
Absolutely.
Awesome. Chelsea?
Hi, everybody. Thank you so much for having this talk. I got my little one right here. I'm an OT supervisor and then a mom of two, and in a Chicago hospital that currently doesn't have a program like this, and very interested in the potential of having starting a program like this. Was just thinking from if you kind of answered this question already about when the volume of patients that you're seeing, given that you're doing standing referrals for all patients, like how you decide who to see, if you're screening patients, and like you mentioned, you may just go in and provide 8 minutes of education and that might be enough, or are you like screening and not even seeing some of the patients, or are you trying to see at least all the patients if you can, and then just talking a little bit about your prioritization process if you have one.
Yeah, absolutely. Great question. So I do try to just see everyone if I have time. Now, if it's super busy, as far as prioritization, I prioritize C-sections. And then once I get through all of those, I prioritize vaginal deliveries with tears. And even if that's just a first degree, it's still probably painful that they're dealing with. So vaginal deliveries with tears, and then vaginal deliveries with no tears. And then adding in medical things too. Or a vaginal delivery with preeclampsia, or someone with, perinatal loss, just kind of adding those different situations in as well. So I do try to see everyone. I do try to encourage everybody to get up so I can see them move around and do an ADL or two. But sometimes, they're just like, I literally just laid down, I'm comfortable, I'm doing all the things. And then I'll just do my like spiel of education, and do a screen. Or if we go into a little bit deeper education, we'll write that up as an eval, and just ask them, how they're doing with everything. But that's kind of like my process of how I triage patients.
And then my last question is, do you run into barriers when you're going to try to see a new mom? Like, I just speaking from experience, like I remember how I was in the hospital and you're just like exhausted. You have constant providers coming in and out of the rooms. You like are saving your energy for just feeding your baby and trying to do all the things. And like, how do you like overcome some of those barriers? And like, what's your typical
Yeah.
day look like?
Yeah, great question. So that is an interesting question, because that is kind of something you run into on this floor, because people are so mobile and they're doing so many things. Sometimes it's hard to catch people. We have a NICU in our hospital too. So a lot of times, like if I have a patient who's baby in the NICU, they're in the NICU the whole time and I can't see them. Or they're like in the shower, like things that you're not used to like having a problem with on like the adult acute care side, because people are just more sick and broken. But these people are like up and moving and doing all the things. My cardinal rule is I will never, ever wake up a postpartum mom. If I walk in and she is asleep, I am not waking her up. I will wake up any other acute care patient, but not a postpartum mom. But you're right. If they're like, listen, I just have the baby like just fell asleep. I just got comfy. Like, cool. And like, so I do have, so kind of to curb that, we made an education packet that I leave with everybody that has all of the education that would go over with it. So if I can't get back to them, they at least have some sort of education that they're going home with. So that was kind of my way to curb that. I feel like there was a second part to your question. Barriers, medically, things too. Sometimes I have to wait a little bit, for them to get off magnesium sulfate. Perinatal loss is another one, unfortunately, that we do see. And sometimes those moms really want to talk about all the things and they want to tell me everything that happened. And, I'm here for all of that. And then other times they don't want to see another soul in that room. And that's perfectly fine too. So that's where that education packet fits in there too. So I think that's where having that helps curb some of our barriers too.
Thank you so much.
What is it? Sorry.
I forgot you see moms who suffer perinatal loss.
Yes, we do.
Yeah. And that's after any delivery type. So that's also inclusive. Like, are those automatic orders as well?
Yep. So because they get those postpartum orders, we see them as well.
Wow. Okay. I
Yep.
think Stephanie is next. Stephanie?
Hi. So I was wondering if you have a copy of your strategic plan that you'd be willing to share. And also I was wondering if you at your hospital have PTs that see the postpartum patients too, and if so, how do you delineate your roles and who does what?
Yeah, great questions. Sure, I'll share my strategic plan. That's no problem. Maybe just put your email in the chat and I'll get that emailed to you.
Thank you.
And right now we only do OT that sees patients. So as the sole person that created this program, I just did it as OT. I did have a couple of PTs that were interested in doing this whole, full time. We just, honestly, no one has kind of just been like, our PTs are really busy too. So we just kind of like have just been OT. And then when we need a PT referral, the providers that I work with are really great about putting that in. And then if one day one of my PT friends is like, okay, I'm ready to do this full time, like I'm going to talk to management about it, then I will gladly, welcome them on. But for now, it's just been OT. And again, if there's something going on that is out of my scope of practice, our management and our OB providers are really quick to put a PT order in and we get them seen by PT.
Thank you.
Hey, I am an OTD student, very early stages. I don't even have a capstone advisor yet, but I will get one within the next 1 to 2 months. And I know your story is a little bit different because you started as a practitioner, and I believe, did you get a post-professional doctorate? Okay, yeah. So I was wondering how I guess capstone would be different for an EOTD, and also if you had any good like initial steps and contact information.
Yeah, so I just talked to someone about this the other day. I guess my best advice would be finding an OT who is willing to, finding a hospital that has this program started already. So that way you can be with that therapist and then, start this work with them. And maybe starting, kind of another sub project with them. Or if you can't find a hospital that's close to you, finding a therapist at any hospital that would be willing to start this program with you would be my best advice. My little guy wanted to come say hi too. Hello, come here. This is my little guy Shepherd. He wanted to come say hi. So yeah, finding a therapist that would be willing to start this program with you would kind of be the next best step, I think. Either starting the program, or I had a student that came with me and she started our antepartum program for her capstone project because I had already started our postpartum program. She came to me and started our antepartum program. So we get antepartum patients that are admitted for a couple days, months, weeks, whatever. And we started a group therapy project with them. So that's another route. If you find a therapist that already has started a postpartum program, you kind of get the benefits of both worlds of doing your project, but also seeing postpartum patients as well. And then if you're just going on your own, finding a therapist who's willing to start the program with you, which again, I can send you all of my information of why you should start these programs that you can give to that therapist and say, we'll do it together. I hope that was helpful.
Yes, thank you so much. I would love your contact information.
Yep, for sure.
Thank you so much for your time and also just for like being willing to provide resources. This absolutely qualifies for what we're doing in terms of the maternal rehab project. So more to that in an email to you, Dr. Sisler. I just want to let you know I am honoring your time tonight. Wow, like there has to be a part two because you have questions that are unanswered. Anytime we leave one of these with more questions than we have time to answer, it's a really good sign. And just the value you provided is incredible. And so pace yourself. I know a lot of people will be reaching out to you, but if there's a way to consolidate the information that you want to, share with people today, let's talk about that. And everyone, I have saved this chat. I will save this chat. I'll send any unanswered questions. If you just want to drop any last minute questions in the chat, so that Dr. Sisler, might be able to answer, or we'll even have maybe a little fax. But I think that's going to be the end for tonight.
Sounds good. Yeah, no, it's always a joy and a pleasure to come talk with you and to talk with anyone. And I am always happy to come back and answer more questions because I love talking about this, and it's always a joy to work with this population and these little guys here when they're itty bitty brand new in the world.
Same. It's just rare to find someone who's willing to share that much about how their program started. So thank you again. But yeah, we'll get in touch and have a great night, little one. Have a great night.
Thank you. See you too. Can you wave?
Thank you so much, everyone.
Bye.
Thank you. We will answer your questions and we'll get back to you. Thank you so much for being here. Bye.